Understanding the WISeR model? AI in Medicare prior authorization. The future of healthcare regulation is here, and it's powered by AI. But here's where it gets controversial. The new WISeR model, set to launch in 2026, could fundamentally reshape how Medicare handles prior authorizations for medical services. This bold experiment by the Center for Medicare and Medicaid Innovation, CMMI, aims to cut waste in healthcare spending by deploying artificial intelligence, AI, and machine learning, ML, tools to streamline approval processes. Yet, as with any disruptive innovation, this raises critical questions about fairness, efficiency, and the balance between cost control and patient care. Let's unpack what this means for providers, patients, and the broader healthcare ecosystem. What exactly is the WISeR model? CMMI has unveiled a 6-year initiative called the Wasteful and Inappropriate Service Reduction, WISeR model, designed to test AI/ML systems in managing prior authorizations for Medicare Fee-for-Service, FFS beneficiaries. Unlike traditional models that rely on human reviewers, WISeR will leverage algorithms to assess whether specific medical services or devices meet Medicare's criteria for coverage. This includes everything from spinal surgeries to advanced sleep apnea treatments. The model's core goal? To reduce unnecessary care by identifying and blocking low-value procedures, a strategy that aligns with CMMI's new strategic focus on preventive care under the Trump administration. The controversial twist, incentivizing tech companies while CMMI frames WISeR as a voluntary program, the reality is more complex. Providers in 6 states, Arizona, New Jersey, Ohio, Oklahoma, Texas, and Washington, will be required to comply with its rules. Here's where the debate intensifies. Participating technology firms will earn a percentage of the savings they generate through their AI/ML tools. This shared savings model creates a financial incentive for tech companies to deny unnecessary claims. But critics argue it could inadvertently prioritize cost-cutting over clinical judgment. Imagine a scenario where an algorithm denies a legitimate but costly treatment simply because it doesn't align with historical spending patterns. Is the system optimizing for efficiency or patient outcomes? This is the part most people miss. The model's success hinges on balancing algorithmic precision with human oversight. Licensed clinicians will review denial decisions as a final check. But can they realistically keep pace with AI-driven processes? Who's on the list? A closer look at targeted services. WISeR initially focuses on a curated list of high-cost, high-variability services, including nerve stimulator therapies for Parkinson's and essential tremor, epidural steroid injections for chronic pain, cervical spine fusion surgeries, hypoglossal nerve stimulation for sleep apnea, and more. CMMI explicitly states this list may expand over time. Providers must stay vigilant, as even minor shifts in criteria could disrupt workflows. For example, if a new procedure is added to the list tomorrow, hospitals could face delays in treating patients while they navigate updated approval protocols. #What providers need to know right now. If your practice operates in one of the 6 WISeR states, preparation is non-negotiable. Key steps include: 1. Audit your current practices. Review how often you use WISeR targeted services. Are there opportunities to align with Medicare's coverage guidelines proactively? 2. Train clinical staff. Ensure clinicians understand how to document medical necessity with precision. A vague note like "patient needs this" won't cut it. AI systems thrive on structured data. 3. Master submission protocols. Coding and billing teams must learn WISeR-specific rules. For instance, should you submit a prior authorization request or risk prepayment review? The latter could delay payments by months. 4. Explore the gold card option. CMMI is testing a system where providers with a 90% approval rate could bypass prior authorization entirely. This could be a game changer for high-performing clinics, but only if they can maintain consistent compliance. The bigger picture, efficiency versus equity. WISeR's proponents argue AI will eliminate bureaucratic delays and reduce administrative burdens. However, skeptics warn of unintended consequences. Will rural providers with limited resources struggle to compete with urban hospitals that can afford AI-savvy compliance teams? Could patients in underserved areas face longer wait times for approvals? These questions highlight the model's most contentious aspect. Can technology-driven cost savings coexist with equitable access to care? Final thoughts and a call for debate. As WISeR rolls out in 2026, healthcare providers must brace for a paradigm shift. The CMS launches WISeR program, Prior Authorization for Medicare Services. This initiative aims to redefine traditional Medicare by introducing a new model that could shift the balance between care quality and cost efficiency. However, this approach may inadvertently prioritize efficiency over patient outcomes, sparking debates about the role of prior authorization in healthcare systems. But here's where it gets controversial. The Wasteful and Inappropriate Services Reduction, or WISeR model, introduces a requirement for prior authorization on certain procedures. Although the final decision lies with licensed clinicians, these contractors will receive payments based on their ability to reduce unnecessary or non-covered services, aiming to lower costs. Gretchen Jacobson, Vice President of Medicare at the Commonwealth Fund, emphasizes the importance of timely data to address challenges moving forward. She highlights that delays in care can have significant negative impacts on both patients and the Medicare program. Delays can also lead people to get frustrated and end up paying out of pocket for care that should be covered, she says. WISeR will launch in a handful of states beginning January 1, 2026. Targeting outpatient procedures such as skin and tissue substitutes, electrical nerve stimulators, and knee arthroscopy for osteoarthritis. These programs only cover a narrow range of services and will be rolled out in limited states, but they hold the potential to grow if successful. Juliette Kubansky, Deputy Director of Program on Medicare Policy at KFF, notes that innovation centers can potentially expand nationwide if they meet targets. One appeal of traditional Medicare is unfettered access to providers and services because there are no prior authorization hurdles. If the WISeR model gains traction and expands the list of services subject to prior authorization, it could challenge the appeal of traditional Medicare for providers and beneficiaries alike. How the WISeR model works. For each selected service, participants will receive a percentage of the savings attributed to reduced wastefulness or inappropriate care. These vendors will use artificial intelligence to authorize or deny coverage. Payments will be adjusted based on performance against quality and process measures, including faster decision-making for providers and suppliers, and improving experience with prior authorization. Prior authorization may reassure providers or health systems by ensuring payment before submitting a claim, rather than risking a denial after a procedure. Safeguards include reviewing non-affirmations by trained individuals and identifying low-value care associated with those services. However, there is limited transparency in much of this process, a concern raised by experts like Gretchen Jacobson. Machine-driven algorithms are not person-centered, which adds complexity to the system. The 6-year pilot will initially target outpatient procedures, with no plans for inpatient services or high-risk delays. A successful pilot could change this approach. CMS maintains that the model does not alter coverage or payment criteria, allowing beneficiaries to choose providers freely. Participation in the program is mandatory for clinicians in pilot states, though providers and suppliers have options to submit requests or face prepayment reviews. This initiative reflects a broader effort to improve care efficiency and reduce costs, raising questions about whether the focus should shift toward quality over cost. While some argue it addresses fraud, others caution that transparency and accountability remain critical for success. Understanding changes in Medicare prior approval. What you need to know. Are you about to lose control over your healthcare decisions? A seismic shift is coming to Medicare, potentially putting treatment choices in the hands of insurance companies before you even see a doctor. This change centers around prior authorization, and it's sparking heated debate. For years, the traditional Medicare system has largely allowed doctors and patients to decide on the best course of treatment first, with Medicare handling the payment approval process afterward. But that's about to change, at least on a trial basis. Medicare recently unveiled a new model program, designed to test the waters of pre-approval. According to the Centers for Medicare and Medicaid Services, CMS, this voluntary program will run from January 1, 2026 through December 31, 2031 in 6 states: New Jersey, Ohio, Oklahoma, Texas, Arizona, and Washington. The goal? To see if requiring pre-approval for certain services can cut down on wasteful spending. Participating medical providers will need to seek prior authorization for 17 specific items and services. These include things like skin substitutes, deep brain stimulation for Parkinson's disease, treatments for impotence, and arthroscopic surgery for knee osteoarthritis. But here's where it gets controversial. A provider can choose to skip the pre-approval process, but they'll be taking a gamble. It may proceed without authorization. Medicare will review the case after the treatment, and the provider risks not getting paid. Why is CMS doing this? They point to reports showing significant waste, fraud, and abuse within the Medicare system. The Medicare Payment Advisory Commission, for example, estimates that in 2022 alone, up to $5.8 billion was spent on unnecessary or inappropriate services that offered no real clinical benefit. Under this new model, providers will submit the same information they currently use to request payment after a service is provided. The key difference is timing. They'll have to submit it beforehand and wait for approval. CMS plans to use third-party companies to handle the prior authorization requests. These companies are expected to leverage artificial intelligence and other advanced tools alongside medical professionals to review the submissions. And this is the part most people miss. These companies will be financially incentivized to deny unnecessary services, meaning their profits will directly depend on how much money they save the government. CMS assures everyone. Numerous reports and studies have highlighted how the pre-approval process in Medicare Advantage can lead to treatment delays or even cause patients to abandon their treatment plans altogether. What's even more alarming is that a significant percentage of treatments initially denied coverage are eventually approved upon appeal. This raises the question, are these denials truly about medical necessity, or are they simply cost-saving measures disguised as medical oversight? In response to these concerns, over 50 major insurers who sponsor various types of insurance plans have announced a voluntary effort to streamline prior authorization processes across all their insurance markets, including Medicare Advantage. They aim to have these changes in place by January 1, 2027. But will these voluntary changes be enough? Will they truly address the underlying issues of access and affordability? Or will they simply be a cosmetic fix that fails to protect patients' rights? This is a complex issue with no easy answers. What are your thoughts on prior authorization? Do you believe it's a necessary tool for controlling healthcare costs? Or does it create unnecessary barriers to care? Share your opinions in the comments below.